52.4%. I really want you to let that number sink in for a second. That is the staggering rate of total penicillin resistance found in pneumococcal clinical isolates in Sri Lanka. And why does this matter so much? Well, because when community-acquired pneumonia puts a patient in the hospital, the mortality rate can range from 10% up to an absolutely terrifying 40%. The stakes literally could not be higher. We are dealing with an infection that is rapidly outsmarting our traditional defenses.
Welcome to this explainer. As we dive into the source material today, we're going to look at this deadly respiratory illness through a very specific lens. Basically, we're treating it like a crime scene. We're going to put on our medical detective hats and uncover the exact framework frontline physicians use to investigate, identify, and neutralize pneumonia. By the end of this, you'll understand exactly how the pathogens threatening patients' lives are actually tracked down.
Here is our investigation roadmap. First, we'll identify the pneumonia suspects. Second, locate exactly where the infection was acquired. Third, gauge the overall threat level. Fourth, deploy our treatment strategy. And finally, we'll examine what happens when severe complications arise. Let's get right into it.
All right, Section 1. The pneumonia suspects, identifying the culprit.
So right off the bat, we've got a major divide in our suspect list. Typical versus atypical pneumonia. And this isn't just a naming convention, it's like a totally different crime scene. Typical pneumonia, which is often caused by Streptococcus pneumonia, launches this full frontal assault on the alveoli. The patient comes in with classic signs, right? Fever, a productive cough, and a huge spike in neutrophil white blood cells. If you look at their chest x-ray, you're going to see a clear-cut, solid lobar consolidation. But atypical pneumonia, which is caused by these stealthy organisms like Legionella or Mycoplasma, acts completely differently. It primarily targets the interstitial space between the alveoli. So the physical signs are super subtle, maybe just a few crackles when you listen to their breathing. And the x-ray? It just shows patchy bilateral infiltrates rather than a solid block of infection.
But here's what's truly fascinating. How do brilliant medical detectives actually nail down these atypical suspects? Well, because atypical pneumonia is so subtle in the chest, the pathogen actually leaves fingerprints elsewhere in the body. For example, if blood tests show severe hyponatremia, which is a dangerous drop in sodium levels, that is a massive neon sign pointing straight to Legionella. On the flip side, if the patient develops cold agglutination, this bizarre autoimmune reaction where red blood cells literally clump together in cold temperatures and cause hemolytic anemia, your primary suspect is almost certainly Mycoplasma.
Moving on to Section 2. Where was it acquired? Locating the source.
Okay, so the absolutely crucial point here is this strict 48-hour hospital admission threshold. This invisible line literally changes our entire suspect list. If a patient develops pneumonia out in the community or within the first 48 hours of being admitted to a hospital, we classify it as community-acquired pneumonia, or CAP. But if that pneumonia strikes after the 48-hour mark, it becomes hospital-acquired pneumonia, or HAP. And if they happen to be on a ventilator, it's VAP. This matters immensely because, let me tell you, hospital bugs are entirely different beasts. They are highly resistant, vicious pathogens that require a completely different, heavy-hitting arsenal of antibiotics.
But if we look at the official clinical guidelines, there's actually this fascinating loophole to our 48-hour rule called healthcare-associated pneumonia, or HCAP. Get this. A patient could walk right through the front doors of the ER and be diagnosed in under 48 hours, but if they have recent healthcare risk factors, we actually have to treat them like they have a dangerous hospital-acquired infection. We're talking about things like residing in a nursing home, getting recent IV antibiotics, or undergoing hemodialysis within the last 30 to 90 days. Their recent environment basically makes them incredibly vulnerable to resistant strains.
Which brings us to Section 3, gauging the threat level, the CURB-65 score.
Let's break down this incredibly efficient checklist. The CURB-65 score is basically the ultimate tool for doctors to decide, in real time, whether a patient can safely go home with oral antibiotics or if they need to be rushed to the ICU immediately. You get 1 point for each criteria met.
C is for new onset confusion.
U is for a plasma urea level greater than 7 millimoles per liter, which shows us the kidneys are under stress. R is for a respiratory rate over 30 breaths per minute, a really clear sign of respiratory distress. B is for dangerously low blood pressure, specifically a systolic under 90 or a diastolic under 60. And finally, 65 represents an age over 65.
Now, applying that score directly to the clinical guidelines, if a patient scores a 0 or a 1, they have a really low mortality risk, like 0.1 to 0.4%. They can usually just be managed safely at home. But, and this is a big but, a score of 3 or more, that places the patient in severe danger, reaching a staggering 22 to 30% mortality risk at 30 days. These patients require immediate, aggressive intervention, almost always in the intensive care unit.
But, Curb 65 isn't the only thing to look out for. Medical detectives are always on the hunt for other massive red flags that point to a severe systemic threat. 2 critical danger signs on the lab reports are leukopenia and severe acidosis. Normally, an infection causes your white blood cell count to spike, right? Because your immune system is fighting back. But if a pneumonia patient has leukopenia, which is a white blood cell count below 4,000, that is a terrifying sign. It means the immune response is totally inadequate and is basically failing. Similarly, an arterial blood gas pH dropping below 7.2 indicates profound acidosis and metabolic failure. Both of these scenarios demand immediate critical care.
All right, Section 4, the treatment strategy. Deploying countermeasures.
So, looking at the actual clinical algorithms for hospital-managed community-acquired pneumonia, doctors really have to act fast. For standard cases, they'll immediately deploy empiric antibiotics. That basically means starting treatment before the lab cultures even confirm the exact bug. A really common combination is a third-generation cephalosporin, like ceftriaxone, and they'll often pair that with a macrolide to make absolutely sure they're covering both those typical and atypical suspects we discussed earlier.
Now, in contrast to that, the protocols for hospital-acquired and ventilator-associated pneumonia, they are significantly more complex. We're dealing with highly resistant hospital pathogens here, like Pseudomonas or MRSA. So the urgent need is for incredibly broad-spectrum empiric antibiotics right out of the gate. And on top of that, these guidelines heavily emphasize the need to get precise quantitative cultures from the lower respiratory tract. You see, we need exact microbiological data so we can eventually de-escalate those heavy-duty antibiotics and target the specific bug.
Let's take a really close look at the precise sequence required for these treatments, because honestly, timing is everything here. Step 1 involves this super fascinating detail: giving steroids. Guidelines actually suggest giving 6 milligrams of IV dexamethasone, ideally before the first dose of antibiotics. Why? Well, because when antibiotics shatter those bacterial cell walls, it triggers a massive and sometimes fatal inflammatory response in the lungs. The steroid blunts that cascade. Step 2 is getting those empirical antibiotics into the patient's veins within 1 hour of identifying severe signs. And then step 3 is adjusting and streamlining the therapy days later once the actual cultural results finally come back from the lab.
And finally, Section 5, when complications arise. The investigation deepens.
Okay, so one of the most severe complications we're constantly hunting for is called an empyema. To translate that out of medical jargon for a second, just imagine the fluid-filled sac surrounding the lungs, the pleural space. Normally, it just provides lubrication. But in an empyema, the bacteria from the lung directly invade that space. It ceases to be a simple effusion and literally turns into a pocket of frank, thick pus pressing right against the lung. This requires urgent intervention, often meaning surgical drainage or a chest tube, because antibiotics simply cannot penetrate that thick collection of pus effectively on their own.
So to definitively prove this empyema diagnosis, an ultrasound is used to guide a needle in to aspirate some of that pleural fluid. And in the lab, aside from the very obvious visual of frank pus, we're looking for a glucose level below 6.2 millimoles per liter. Why glucose? Because the living bacteria in that fluid are literally eating the glucose for energy. We also look for a pH below 7.2, because as those bacteria metabolize, they spit out acidic waste. These chemical markers, along with a positive Gram stain, confirm the diagnosis for sure.
Another truly terrifying complication is a lung abscess. So instead of pus outside the lung in the pleura, this is a localized collection of pus deep inside the lung tissue itself. A mix of aerobic and anaerobic bacteria literally digests and destroy the lung parenchyma, creating this thick-walled cavity. If you look at a high-resolution CT scan, you'll often see a distinct fluid level within this cavity and air-liquid interface where the pus basically settles at the bottom. Clinically, the patient will often cough up large quantities of incredibly foul-smelling sputum due to those destructive anaerobic bacteria. It is a devastating condition that requires very prolonged antibiotic therapy, sometimes lasting anywhere from 4 to 6 weeks.
Which honestly brings us right back to where we started. We've got this incredible investigative framework, right? We have SERB-65 scores, precise algorithms, advanced imaging, all to track down and fight pneumonia. But look at this final question. With penicillin resistance sitting at a staggering 52.4% in some regions, the very weapons we rely on as medical detectives are losing their firepower.
The clinical guidelines are constantly having to adapt to outsmart these resistant pathogens. So I leave you with this to ponder. As the bugs get smarter, how will we treat these standard respiratory infections in the coming decades? Will our medical detective work be enough? Thank you so much for joining me on this explainer. Keep asking the hard questions and keep learning.